Well, good afternoon, everybody. Thank you so much for staying with us this afternoon. We're going to talk a little bit about the things that we have learned in the last year. I don't think any conference these days can really be complete without a discussion of how the COVID pandemic has affected all of us and continues to affect how we take care of our patients. I do have a few disclosures, none of which are relevant to this conversation. But I wanted to talk a little bit about sort of where we're at. Certainly this last year has been challenging on many levels. The worldwide infection rate at this point is about 135 million people have had confirmed COVID cases. In this country, we've had over 31 million people who have had positive COVID tests, and that has resulted in more than 500,000 Americans losing their lives to this disease. But I do think that there is good news, and the good news is that we have immunizations now, which is going to be how we get this disease under control in the next year. About 179 million doses have been distributed and put in people's arms in this country at this point, and that's about 3 million doses a day. So we're well on our way to hopefully getting a lot of our population vaccinated. And worldwide, that number is 750 million doses. So we're really getting a lot of vaccine out there, but we have work to do. But COVID obviously has been more than just numbers. It's all affected all of us personally and some of us in very intimate ways. If you've had COVID, if you've known people who've had COVID or lost relatives to COVID. But at the beginning, a lot of what we thought about was how do we protect ourselves? How do we protect our patients? How do we protect our team as we navigate this new challenge? And so lots of us came up with interesting ways to try to put barriers up in the operating room to help our patients and help our team to minimize aerosolization. I came up with this idea using a Voelker retractor to sort of hold our double drape that the UK groups had talked about and put some slides out about. And it worked okay. I wouldn't say it was great, but it worked. And then additionally, there were challenges on the work front for me as a residency program director, thinking about how do we continue to move our education process forward in these new ways. But it's not just at work. Obviously, COVID has affected us in our personal lives as well. And so now we do things on Zoom socially. We physically distance ourselves in those places where we can't do things virtually. We do our recreation in different ways now and have to be physically distanced and safe that way. But I also think it's given us all an opportunity to sit down and think about the things that are really important to us. And hopefully you've had a chance to maybe smell the flowers a little bit as well in this really unprecedented time. I think that was the Webster Dictionary's 2020 word of the year, and it continues. So without further ado, I'm going to introduce our panelists today. We have a international group here to talk to us a little bit about COVID and how it's affected us in our professional sphere. So I am Sarah Mowry. I'm from the University Hospitals Cleveland Medical Center, Case Western Reserve University School of Medicine. We'll be joined from South Africa late at night, who's stayed up to hang out with us today, Professor Shivesh Maharaj, who's the department head at the University of Witwatersrand in Johannesburg, South Africa. And very early in the pandemic, his group put out some information about manifestations, not only otologic, but also some other head and neck manifestations of COVID. And so he's going to talk a little bit about their experience and hopefully a little bit about the South African experience with this disease. We'll be followed by Dr. Courtney Voelker, who's at the University of Southern California Department of Otolaryngology. And she's been working on a grant regarding telehealth and telemedicine and how this is, and looking forward into the future, how this will affect our practices. Dr. Sonya Malekzadeh is the residency program director and the chair of the Organization of Program Directors in Otolaryngology within the Society of University Otolaryngologists she's from Georgetown University, and she'll be talking to us a little bit about impacts of the COVID pandemic on how we educate. And that's going to obviously include some virtual stuff since we're doing that all today as well. And lastly, we're joined by Dr. Jennifer Nuzzo, who is a senior scholar for health security and an epidemiologist at the Johns Hopkins University Bloomberg School of Public Health, excuse me. She's an expert in vaccine security and distribution, and she was recently featured on NPR for her work around the COVID vaccine distribution. And so we have a radio celebrity joining us today as well. So without further ado, I'm going to turn it over to the professor, Maharaj. And at the end of the session, if you could, we will answer our questions then. So please put your questions and discussion points in the chat, and I will pose them to our panelists here towards the end of that. So I'm going to stop sharing and turn it over to the professor.
Good evening from South Africa, and I suppose good day to you in America. Thank you to the ANS Society for affording me the opportunity to present some of our work. The coronavirus is something that has affected us, as Sarah pointed out, not only in our professional life, but in all spheres of life. As we know, the coronavirus are large enveloped RNA viruses that have caused mild respiratory infections in animals and humans in the past. And there have been two outbreaks in the past, the SARS virus in the Middle Eastern, or the MERS virus, which luckily didn't make it to the South African shores. So as mentioned, I am Professor Shivesh Maharaj from the University of the Witwatersrand. And today I'm going to talk to you a little bit about the coronavirus and the impact of the pandemic and the features within our population. So despite the neuroinvasive properties of the coronavirus, there have been no reports of inner ear or vestibular cochlear nerve disorders associated with previous viruses. However, we do know that viral upper respiratory tract infections have been linked to new cases of otitis media. The common symptoms of the coronavirus were first described, and they included the fever, fatigue, and dry cough, as described by Krauska. Thereafter, a whole lot more of the upper respiratory tract infection, upper respiratory tract symptoms were included, as well as myalgia. We specifically looked at an alteration in taste, smell, hearing, and balance under the broad umbrella term known as chemosensitive dysfunction. And the trends that we noticed in our patients was that they presented with a loss of smell and taste much more earlier than any of the other symptoms and signs during the disease. The loss of smell and taste was often seen by itself and not associated with other symptoms such as rhinorrhea and nasal obstruction. One of the issues that we had was to try and quantify this and to develop tests so that we can measure the frequency, extent, and clinical characteristics of these dysfunctions. Obviously, these tests need to be validated and repeatable, as stated by Vieira. So in terms of taste and smell, there is a little bit of a difference, although the degree is the same, but the taste initially may be a complete loss of taste and then a distorted taste. Whereas with smell, there's a loss of smell and then a reduced ability before olfactory hallucinations. So what causes this? The exact pathophysiology is not well known. However, we do believe that it's viral invasion of the epithelial cell types that have the ACE2 receptors. There may be further inflammatory response pathways from the infection of neuronal and non-neuronal cells. Unusual presentations of the disease include tinnitus and hearing loss. and these otologic disorders may herald the onset of the COVID-19. Hearing loss may also be documented as a late complication of the disease, which is a bit different to the taste and smell disorders, which is often found earlier. So viral infections have been implicated in both congenital and acquired causes of hearing loss. These may be both unilateral or bilateral, and the hearing loss is typically sensorineural. However, conductive and mixed hearing losses have been documented. So here the pathogenesis is a bit different in that we believe it may be a cross-reaction between the viral particles and antigens within the inner ear. The virus is also transmitted via CSF, and they may be associated with brainstem involvement, and this is due to attachment of the coronavirus to the ACE2 enzyme surface receptors that are found abundantly on both neurons and glial cells. We believe that the hearing loss, as stated by Cure, may be secondary to ischemia of the hearing senders due to the thrombogenic phenomena related to the SARS-CoV infection. So what we did was we looked at a review much earlier on in the course of the disease in South Africa. And we looked at the otologic manifestations of the SARS-CoV-2 virus. We did a systematic review in accordance with the PRISMA guidelines, where otologic dysfunction was defined as any subjective and objective impairment to the normal otologic, vestibular, and audiologic function of the ear. We identified at that point in time, which was October, 62 articles, and these articles were then screened, of which 7 articles met the inclusion criteria, and they were then analyzed to compile the discussion. So in our results, we found that the distribution of patients, their ages ranged from 20 to 60 years. The overall total number of subjects involved in this study were 28 patients, and the studies originated from throughout the world, including China, Egypt, Iran, Germany, and Thailand. Of note, we had 2 studies that originated from Turkey. All patients presented with hearing loss, and 3 patients had otalgia, whereas 2 patients had vertigo and tinnitus. All of these 28 patients were tested and were positive for COVID using the RT-PCR. 8 of these patients had MRI scans and 5 patients had CT scans. So in terms of recovery, what we found in our setting is that the smell and taste disturbance are quite common, and they usually regress within the first 30 days. Various articles have highlighted that if any treatment modality is to be instituted, it should be within 4 to 5 days, and usually within 20 days. Vieira et al. Also reported that chemosensitivity recovery occurs in the vast majority of infections. However, there may be residual and moderate hyposmia, which ranges between 69 and 28% respectively. So various agents have been used in clinical trials. And as I mentioned before, specific therapies should be initiated within 20 days after disease onset. However, we need to weigh out the probability of spontaneous recovery and potential risks of treatment modalities. So in our setting, the treatment modalities that we've been using for this chemoreceptor dysfunction includes normal saline, which may be topical, especially in terms of the nose, and paracetamol for both its anti-inflammatory and analgesia properties, the mucolytics, as well as corticosteroids, which may be divided both into topical and oral corticosteroids. I did make a note there of vitamins. However, there are not enough studies linking the use of vitamins and recovery within these patients presenting with chemoreceptive dysfunction. And that presents an opportunity to do further work in that area. So my final slide is just looking at the chemosensitive dysfunction found in this pandemic, which had not previously been found in the other 2 outbreaks. And the possible pathogenesis of the smell and taste disorder is very complicated and remains unclear at this point in time. However, the vast majority of patients will recover spontaneously, and we need to weigh in treatment options, particularly in the form of corticosteroids. So I'd like to thank you all for listening and for allowing me to present some of our work. We have more work that's in press, and hopefully you will get to read it as we manage to get it out. Thank you for your time.
Okay, I'm Courtney Voelker from the University of Southern California, and I'm grateful to be on this panel and to present some of our work at USC investigating telemedicine and how it plays a role in not only the medicine in general, but our subspecialty of otolaryngology. I have nothing to disclose. So as this slide is very familiar to how things have evolved for all of us, regular meetings, and has become sort of a stay-hold in our days. But how do we care for our patients during this pandemic? So the importance of the question is, during the COVID pandemic, how does telemedicine and otolaryngology become critical in taking care of our patients and is rapidly expanding? Patient and physician satisfaction are primary healthcare quality metrics, and these metrics are critical data to collect for continued insurance reimbursement for our telemedicine visits. So how do we navigate the world of telemedicine during COVID-19? What is the telemedicine encounter like for the patient? What is the telemedicine encounter like for the physician? And what factors influence this interaction? Looking at the difference between video conferencing and telephone interaction and taking into account various patient demographics. So we investigated at USC, we applied for and were given a grant for a prospective study of patient and physician satisfaction with telemedicine encounters, and what exactly are the results going to be. At USC, we were very fortunate that we already had platforms in place for telemedicine, which, because reimbursement rates were so low before, really weren't being utilized. But once that changed with COVID, we were very quick as a university to get up and rolling really within a few weeks. So our specific aim for the grant, specific aim number 1, assess patient satisfaction with telemedicine encounters with standardized Press-Ganey questionnaire and a validated telemedicine satisfaction questionnaire prospectively. Aim 2, assess provider satisfaction with telemedicine encounters using provider satisfaction questionnaire prospectively. And then finally, aim 3, identify patient and visit characteristics associated with these satisfaction scores. So our first step was actually to collect the demographic information from our patient population that we were looking at. We looked at age, gender, race, preferred language, education, income level, employment, commute time to the clinic, encounter type, were they new patient, follow-ups, post-ops, and how long was the encounter duration. So aim 1, patient satisfaction. We looked at any adult patient greater than or equal to 18 years old in the tertiary otolaryngology clinic between the months of May and July 2020. We analyzed 407 telemedicine encounters, and we looked at the Press-Ganey scores as well as telemedicine questionnaire, and we found that the patients at least didn't feel any worse about their encounter with us over the computer than in person, and even actually a little bit higher. So the patients actually were pretty satisfied. When we looked at the physician satisfaction, we had 15 otolaryngologists within our department. We analyzed 1,011 encounters, both telemedicine and in-person encounters. And actually our satisfaction scores for telemedicine were lower than our in-person encounters. And so the important thing is aim 3, what are the factors that impact these satisfaction scores? So higher patient satisfaction scores were associated with video conferencing rather than telephone encounters, our younger patient population, and our higher patient income. And higher physician satisfaction scores were associated again with teleconferencing. So both groups actually like to look at each other, which is not a surprise in human interaction. And English as a preferred language, and follow-up visits. So these three were the impacts for how the physician felt about their encounter. So what are the challenges? I think the challenges perhaps are specific to our surgical subspecialty regarding this specific study. Obviously, we only looked at otolaryngologists. We are a procedure-focused surgical subspecialty, and we can't examine the patient over telemedicine. We can't perform our procedures over telemedicine. And for a lot of us, we went into medicine to actually do those things for our patients. So perhaps that impacted the surgeon scores. So in conclusion, the patients actually felt pretty good about their interaction with us over telemedicine, even higher than our in-person visits. Perhaps we're not as rushed, perhaps they're happy to get their problems talked about during the pandemic where access is a problem. However, for physicians, we actually felt had a little bit lower scores for our telemedicine appointments compared to in-person. The most impactful were video conferences, English as a first language, and established patients that we already knew and probably had a rapport already. So lessons learned during COVID-19 pandemic can be expanded to our clinical practice beyond this pandemic. I think telemedicine is here to stay, and it probably took this pandemic to push it into our practice routines, but it's not perfect. And adequate technical support for patients and physicians is paramount. I think there's an issue that we need to be aware of, that perhaps as we use telemedicine more and more, this may widen our healthcare disparities, especially impacting the elderly, non-English speakers, and our immigrant population that may not have access to technology as readily or technology literacy. Interpreter services that can integrate with video conferencing platforms are vital. I know I was struggling and fumbling along with translation services, holding it up to the computer. You know, if we could integrate this into the conferencing services, that would be a benefit. But one great thing is that I think we'll be able to reach greater geographical distances for patient care. Obviously, it's not perfect. Obviously, we need to examine and perform our procedures on patients, but at least it's a start for gathering information and also checking in on patients postoperatively, where I think we can cut down on some of the visits and the long distance of driving that a lot of patients have to endure. So I want to thank the research team. I had a lot of people working on this and collecting data from text messages and emails from patients. Janet Choi was the major pusher of this project. She's going to be an upcoming neurotology fellow at University of Minnesota this coming year. And we had quite a few medical students and residents. So I want to thank everybody, and thank you, Sarah, for having me on the panel.
Good afternoon. I'm Sonya Malekzadeh, joining you from Washington, D.C. Thank you, Dr. Mowry, and to the ANS for the invitation to participate in this panel. As we close another academic year, having fully been in this pandemic, I think we can reflect on the effect of the COVID-19 pandemic on medical education and to sort of figure out what those lessons learned might be. Again, I think we can all agree that the impact of COVID-19 on medical education and professional training has been disruptive, to say the least. But I think the silver lining is that it has motivated us as an academic community to revisit our current education and training paradigm and look for opportunities to improve an imperfect system, if you will. I don't have any disclosures, and I don't need to belabor the effects of the pandemic. There were innumerable difficulties, some immediately obvious, others were certainly more insidious. There's been a lot of conversation around this at COSM this week. But the initial focus was, and appropriately so, on the immediate risk to patients and our healthcare workers and how we would need to protect them. Those of us who work in teaching hospitals, we have to balance the priorities between patient care and trainee education, and the extent of the negative effect of the pandemic on training really became increasingly clear early on, and it was quite profound. And we saw widespread disruption of medical education across the undergraduate as well as the graduate areas. Examples, as you're well aware, include reduced teaching for multiple reasons, faculty being pulled away, some had to be quarantined, they were ill, medical students were pulled off rotations, to preserve PPE, but also for their safety. We halted all of our local and international travel, all the conferences and meetings were canceled. Our residents and fellows were redeployed to meet the needs of other areas of the hospital, the high impact COVID areas. And many of us had to restructure our residency programs to, a 50% model where some were in the hospitals, others, the other half were at home, one to just sort of keep safe and away from the virus, but also to sort of serve as a backup pool should the need arise. I love this diagram. This comes from the Journal of Thoracic and Cardiovascular Surgery. They very nicely put together all these issues that affect our medical trainees into a series of relevant interconnected elements, is how they described it, of the trainee experience. And these were all the things that we had to address as medical educators and as faculty and academic departments. Certainly loss of operative experience. That was particularly devastating, especially to our senior residents and fellows. Loss of face-to-face educational opportunities, again, with the cancellation of didactics and our conferences, the concerns about safety, the PPE shortages. What about our graduating residents and fellows with examinations, interview process, the job market was questionable. And all of this really did amount to a very real mental health and social well-being issue and sort of things that we had to consider. And then the question became, how do we maintain the integrity of surgical training while also protecting our trainees and ensuring that we had this critical workforce for our healthcare system? How did we pivot? And I want to frame the next couple of minutes today around these three topics, which I think address all the other issues that were on the previous slide. So restructuring surgical learning, adapting our current educational milestones and regulations that go around medical education, and then prioritizing safety and wellness for our trainees. Despite, again, this public health crisis, as faculty, we couldn't really fully abandon the education of our residents. We had to march on with this, and educators across all the surgical specialties spent an inordinate amount of time rethinking surgical education. We had to restructure. We had to adapt what this article calls the 3 pillars of surgical learning, which are the educational didactics, preparing for operative cases, and skills development. So in terms of educational didactics, again, we've said this, traditional in-person lectures, didactic sessions, those all transitioned to video-based and recorded teaching sessions. Virtual learning did allow us to maintain some sort of semblance of an educational program. All lectures, grand rounds, didactics, everything became virtual. And I think one of the biggest wins for us as a specialty was the development of a otolaryngology online lecture series. And this was developed to enhance and supplement resident curriculum. It was initiated at the University of Southern California, grassroots efforts from the California programs. They rapidly organized a series of online didactic lectures and invited residents from all over the country to dial in and participate. It was very popular, very well received. And then from that stemmed 2 other lecture series. Dr. Mowry was the lead on that for the Midwest. And then we also had one from the University of Kentucky. And the goal with that was to provide residents with different time zones and different times of day so that they weren't boxed into one particular time frame. But with that, again, comes Zoom fatigue. Zoom engagement is an issue. And although virtual learning has the positive aspects of allowing us to increase, participation and number of participants, and you can widely disseminate important information, give everyone some sense, of camaraderie and connection, even though we're not in person. At least I'm happy to see all of you via Zoom today. But I think there are some downsides, again, with the Zoom fatigue and the engagement. Other things that were done from a virtual platform, within our departments, we all had our journal clubs, our mock orals became virtual, clinical care education, our M&Ms, our tumor boards, and then national conferences, webinars. Our societies were wonderful in putting together programs, the AOHNS, SUO UPDO, and certainly COSM today, and online learning and on-demand learning. So a lot of society created content that's out there. Podcasts became incredibly popular. I think HeadMirror, which comes out of Mayo, and ENT Frequency from the Academy, very popular podcast series, educational, and then social media. We'd used social media in the past for education, Twitter, but I think that has really ramped up quite a bit. The operative preparation. So our residents, they're not spending time in the OR. They did not have the opportunity to stay abreast of any of the operative education, and they couldn't really learn any of the details of procedures. So through these peer-reviewed video-based education models that exist out there, this was an opportunity for them to really engage and to access a wide variety of operative videos. Again, a lot of open access, peer-reviewed products that are out there. And then YouTube, of course, is very popular. I sort of feel like it's a little bit of the Wild West. It's not peer-reviewed, but there is some great content there. And then skills development. So those decreased operative volumes could lead to skill decay. And this was an opportunity for remote learning. Many couldn't get to the sim centers. I know there was a lot of discussion about using simulation to supplement. But again, because of the physical distancing and social distancing issues, those simulation centers were not necessarily always available. So, peer learning, some of the simulation centers allowed scheduled time, which seemed to work, but a lot of at-home models and instruments. If you look at what the general surgery, our general surgery colleagues have done, they were using suturing kits and box trainers, and via Zoom, they were interacting with their faculty or senior residents to get feedback on their skills. And then I also want to touch on our educational milestones. So, I think we needed to have some flexibility and support from our overseeing regulatory and accreditation bodies, such as the ACGME, the RRC, the ABOHNS. And, it was really encouraging to see the early communication and guidance from these organizations, especially in those times of uncertainty. We all live and die by the key indicators that are set by the ACGME, and it was great that they actually, I don't want to say they turned a blind eye, but they were not strict about this, and they left it up to the program directors and the clinical competency committees to determine the competency of the residents and whether they could be promoted and graduated. And I think that's an important point. I think our educational models really need to change. There's been a lot of discussion about surgical education and that it should center on competency and not necessarily these numbers, which we have been hanging our hats on. And then, of course, the ABOHNS, they provided temporary changes to our training requirements in terms of the PGY1 rotations, other rotations for our residents, and then time off if necessary for quarantining. So they were quite flexible with that. And I think it's important to talk about trainee safety and wellness. The residents, just like many of the faculty, the other healthcare providers are on the front lines. They experience some of the highest risk situations for exposure. They're also struggling with insufficient PPE. Some of the residents became ill. They had to be quarantined. And many were being asked to assume roles that they really weren't part of their specialty training. They're being deployed to the ICU and the emergency department. I know our otolaryngology residents did not necessarily feel comfortable in those arenas. And their preparation for these roles was variable. Many were compelled to acquire these skills on the job. They didn't get any training prior to. And then, many of them were also worried about unfulfilled requirements for training and graduation. They were missing time within their specialty. Housing and transportation concerns, financial distress for many that had spouses who were being furloughed. And then, of course, I think the social distancing that we were obligated to do did lead to and sort of enhance that social isolation feeling. At Georgetown, it was wonderful to see what our wellness center and our wellness champions were able to do for our organization. They rolled out very quickly a series of benefits for our residents. They were willing to cover all their medical bills, especially if they're related to graduation, if they're related to COVID, even after they graduated. They extended healthcare coverage for families as well after graduation. Any lost vacation because they were pulled into quarantine, pulled into COVID coverage was rolled over. They offered emergency loans, interest-free for our residents. They provided alternate housing options. So if the residents didn't feel comfortable going home because of transmitting and bringing home the virus, they offered on-campus housing for those residents. Uber rides, transportation to and forth from the hospitals were covered. Lots of virtual support groups, expanded care for the caregiver, and then 24/7 mental health support for our residents. So that was really encouraging to see the efforts that were put forth there. So how do we prepare, as we come out of the storm? We've been in the eye of the storm, we're coming out of it. Are we going to go back to business as usual? I think it'll be interesting to see how many of those changes are going to be enduring, how much reverts back to normal. But we need to be rethinking about the second phase of restructuring of surgical education. American College of Surgeons has put a lot of work into this. They had a meeting called the Times of Crisis, where they're looking at, how are we looking at skills training and assessment? We should be rethinking that. What are those required numbers of procedures? Is that really even how we should be doing the evaluation and competency for our residents and of course, resident well-being? And if there ever was a time to make lemonade out of lemons, I think it's now. This is, as they say, crisis is a time of great opportunity, and the medical education community has been afforded this golden opportunity to reshape and improve our medical education. And we have some very creative and innovative thinkers, medical educators out there. And I think that we can work to expand what has already been done with our digital content, work on simulation opportunities, curricula for those, embrace this competency-based promotion. I think we need to put a lot of work and thought into that. And I will conclude with this slide that, of course, medical education was disrupted by COVID-19. We adapted very quickly, but I would say we were pretty ill prepared as an academic community. I think this is an opportunity for us to reevaluate our existing model. We have to keep and prioritize safety and wellness for our trainees. We need to work with our regulatory and certifying bodies. And I think that change and transformation are inevitable. And I'm excited to see what this next chapter will be for us in surgical education. Thank you.
Hi, everyone. I'm Jennifer Nuzzo with the Johns Hopkins Bloomberg School of Public Health. I really appreciate the opportunity to speak to you all. I have no disclosures relevant to this conversation. I'm just going to give a high-level overview of sort of where we are with COVID, where I think we're headed, and just kind of the overarching lessons that have come out so far. I know I get a lot of questions these days, sort of like, when is it over? When is it? Where are we going? So I'll try to scope where I think the situation is right now and what that might mean for the weeks and months ahead. So I don't have to go too much into the overview globally, but just to kind of point out that the bottom right-hand corner of the slide, you'll see the epidemic curve daily of new cases. We're unfortunately in a bad situation yet again globally, where the last few weeks surging past 500,000 cases each day being reported by among 192 countries. We are particularly worried about two countries, in India and Brazil, whose recent case numbers are really just surging. And I put on the right-hand side, you can see their epidemic curves. I mean, really steep increases there. On the left-hand side is just showing the case curves of the top most affected countries, just in terms of raw numbers. And that squiggly orange line at the top is the United States. And as you can see, for the first time now, other countries are surging past, first time in a while, other countries are surging past the United States in terms of daily new cases. So I just want to kind of recognize this, because I think earlier there was this bit of a narrative that, the United States was the hardest hit country. And I think every other country that wasn't in that situation sort of, wiped its brow and said, phew, that's close, glad we escaped it. And clearly the idea of any country escaping it is not an accurate one. And this pandemic is still very much playing out. And so how countries will ultimately be impacted impacted by this virus is really sort of yet to be seen because the situation is still quite dynamic. In terms of the United States, we're clearly now in a better spot than we were a few months ago, particularly over the holiday surge, which was our highest historic number, highest number of cases since the beginning of the epidemic in the US. Unfortunately, after a period of sort of declining cases, we're now seeing a bump up in cases, which have largely plateaued, but anyway, it's plateauing in a way that is concerning, given the fact that there's still quite high numbers occurring each day. And so, while it's good that we aren't in the same level of infections that we were over the recent holiday period, and that we are quite considerably lower than that, the fact that there's been recent increases and the fact that we seem to be kind of stalling out at dangerously high numbers is still, I think, cause for worry. On the left-hand side is the kind of depiction of recent spread. Actually, this is from today. So if you want to see where states are, red is obviously not good. It means that they're seeing an increase in cases, and the deeper the red, the more the increase. The squiggle lines on that is also the daily curve. And so you can see where the trajectory is in each state. I put Michigan here because this is the state that we're most worried about at the moment. You've probably heard about it on the news. Two worrisome signs from Michigan, which you can see on the right side. Not only are cases increasing, but we are now starting to see an increase in deaths. And it's fairly typical, something that we've seen since sort of the beginning of this. We started tracking the pandemic, is that cases will typically rise, and then we may, 3 or 4 weeks later, start to see an uptick in deaths and hospitalizations, usually just before that. So the fact that we haven't seen, this week, the deaths have basically the same as the week prior. So, that's generally good news that deaths aren't increasing nationally, except in a few places. But it is also possible that these red states aren't yet at the point that Michigan is, and that in a few weeks we could see an uptick in hospitalizations and deaths in other states as well. Everybody is concerned, of course, about the genetic variants, and they're often used now, I think, to kind of explain any unusual findings in any states of particular concern, just in terms of the abundance with which they've been found, is the B117 variant, which was initially detected in the United Kingdom. There has been some kind of gesturing that what is happening in Michigan is the result of the spread of B117, and it is certainly true that Michigan is one of the states that has been, in which we have found more B117 cases. And given what we know about B117, which is that it has an increased ability to transmit between people and also potentially increased severity, it does sort of possibly explain some of what we're seeing in Michigan. I have to always caution, though, of an overinterpretation of these data, simply because the surveillance for variants is still so poor. There is still huge discrepancy in how much sequencing states are doing, and they're not necessarily sequencing with the abilities to really tell incidence. So it's a bit hard to say, exactly that a rising incident cases is attributable to the rise in the variants. Nonetheless, I am sure the variants are playing some role. That said, we have looked at other states where B117 has also been found, and Florida is the state that has found the most B117 cases. Again, not really sure if it is truly indicative of the prevalence of B117, because the sequencing that's happening between states is quite heterogeneous. But we fortunately haven't seen quite an uptick in cases in Florida. So I am hopeful that despite the dominance now of B117 in many states, that we may not all go the way that Michigan has, particularly as we continue to roll out vaccines and employ all the same public health measures that we've been doing for the last year. They are fortunately still effective against B117. And so that brings me to vaccination efforts in the United States. So Sarah, at the beginning, sort of sketched out how many vaccines have been administered to date. Really, I think, a remarkable clip. when President Biden took office, his initial goal was to vaccinate, to do 1 million vaccinations per day, 100 million vaccinations in 100 days. We have greatly exceeded that to now being upwards of 3 million vaccinations per day. And I think that's really an extraordinary effort. There have been so few points of light in the US response to this pandemic, but the rapid rollout of the vaccines, I think, is one of them. And it is probably the sole reason why I feel somewhat optimistic about the months to come. I am, of course, though, worried about inequities in our vaccination efforts. And though not every state is tracking who they're vaccinating at the level that we would like, including the breakdown by race, ethnicity, those that do, we see some really troubling trends in terms of deep inequities where people of color are far less likely to have been vaccinated than white people. And sometimes this is people try to wave it away, saying that it has to do with the age structure of the population. I put here a link to the New York Times that did analyze some of the data, and you'll see that it's not just because there are more older white individuals in the states where we see some of the deep inequities. So this really speaks to the fact that while it is great that we are rolling out vaccines at a fast pace, we also need to do the slow, deliberative work of making sure we improve the equity of our vaccination efforts by increasing access to vaccines. And that, in my view, has probably been one of the biggest problems, which is that it is fairly difficult still to get vaccinated. You have to really kind of be determined and, refresh your computer a bunch of times and try to sign up on a bunch of websites and really spend a good portion of your day trying to see if you can secure an appointment. And just not all of us have the ability to do that. So we have to make it easier and more accessible if we want to bridge some of the gaps here. So that's just kind of where we are. And then just looking forward, what do I think is going to happen? What may come? So as I mentioned, I am quite hopeful. I mean, I don't love the fact that cases are increasing now in a number of states. Michigan is clearly a worrisome situation. And in my view, Michigan needs more help because when you see a rise in hospitalizations and deaths, when you have a vaccine that can prevent both of those things, it is, in my view, a tragedy. That said, we got so lucky with these vaccines, and I really do think that they are going to pave our pathway back to some level of normalcy, possibly sooner than we would have anticipated. And I think Israel, everybody's looking to Israel to see what is potentially in our future. And if it is applicable to the United States, and I think in some ways it is, then it is an optimistic future in the sense that, Israel got going quite early with its vaccinations. Around mid-December, they started vaccinating. They obviously were headed into a surge, a wintertime surge, just like we did in the United States. But now they're in a much different situation. I mean, the vaccination, they've covered almost 60% of their population with vaccines, which is quite extraordinary. And they did this in the context of having a fair amount of B117. So I think that we should take from this some hope that even with the variants circulating, with vaccines on hand, we can find ourselves in a much different situation, I hope, in the next few months. I think this summer will look a lot different than last summer. I think this summer will feel a lot more normal, and I think the fall will also feel a lot more normal here in the United States. That said, globally, the picture is a lot bleaker. And that's a wild card because the US is not isolated by any means from the rest of the globe. And in particular, I'm deeply worried about lack of access to vaccines globally. It's quite obvious that the countries that have vaccines on hand and are using them most are the countries that are richest. And we have a real problem of just simply not having enough vaccines for the world. And also the fact that vaccines are being allocated quite inequitably. So when you have a situation where the United States has more than enough vaccines to cover its high-risk groups, and and the rest of the world doesn't have enough, many countries don't even have enough to cover their healthcare workers or their most vulnerable populations, it is, I think, a really dangerous situation to be in. And so this is, I think, while it's one thing to kind of sit back and feel a little bit better about our situation here in the United States, I think we also have to recognize our obligation to participate in global efforts to end this pandemic. I'm also worried about vaccine uptake. We haven't yet seen the impacts of this in the United States, but it's coming. It's actually, we're already starting to see signs of it where states are, even allowing residents from other states to come and get vaccinated because they have more vaccines on hand, where they're starting to cancel appointments because people aren't signing up. I think that initial surge of interest were the people who were going to get it no matter what. But we still have a lot more work to do to reach people who are on the fence and people who may not even be on the fence, but maybe have already decided that they're not going to do it. It is imperative that we reach people. I think it's actually possible. I think sometimes we, write people off as just being uninterested, and we don't think that we can, change hearts and minds. But I can tell you, I've done a number of deliberative sessions with people who have been hesitant, and they all come with very similar questions and very similar concerns and very similar misinformation that they've heard or seen spreading online. I've been working in pandemic preparedness for 20 years, and I have to tell you, the level of mis and disinformation that's circulating now is not like anything I've ever seen before. It's so pervasive, and it's not limited to the fringes of society. I have heard false information, conspiracy theories coming from very senior educated people who just saw something and just, didn't know that it wasn't true. So we have a lot more work to do. And I think that's going to be critical for the next phase of efforts here in the United States, but also globally. I mean, there are some polls emerging that shows fairly high levels of hesitation in countries, including countries that don't even yet have the vaccines. Now, one would hope once those vaccines start being used that some of that hesitancy will shift a bit, but it does really worry me that we are starting from this place and we have a lot more work to do. And that's, again, slow, deliberative, really hard work, but essential work. And I just want to say that, in terms of kind of the future and what ultimately COVID-19 will have done to us, I think it's worth kind of remembering that the impacts of pandemics are kind of multiple, and you can kind of bin them into three categories. So, we've known and we've seen and we've heard about the people who've been directly affected by the virus, the staggering losses in terms of illnesses and hospitalizations and deaths that have occurred. We track those numbers. Then, of course, there are the kind of the health effects that are COVID related, but not COVID caused. So the disruption in care that occurred perhaps due to lockdowns initially, or people not seeking routine or preventative care out of concerns about contracting the virus. And I think we are starting to see from some of the excess death analyses that are coming out that that's a considerable amount of people who died in numbers that exceed what we would normally expect. In the US, I've heard that the deaths typically fluctuate on a year-to-year basis from around 2%. But a recent study on excess deaths in the United States, looking at the last, since March, saw a 23% jump in deaths during that time period. Not all is COVID. Some of it is the heart attack that happened at home that could have potentially been saved, had someone sought care at a hospital. So I think we're still going forward, enumerating the tolls of this pandemic. And then there's the economic side. And I say this not because of this unfortunate sort of politicized debate we've been having for the last year, which is, do you try to control COVID or do you protect the economy? It's a completely false argument. You have to do both. You cannot protect the economy if you do not have a healthy public. People aren't going to go out and spend money if they are afraid for their lives. However, people cannot be healthy if they have to worry about putting food on the table to feed their family. They cannot comply with public health interventions if it means losing an income. So public health and the economy are inextricably linked. That said, the costs of COVID have been staggering, and governments have responded in a variety of ways. I think overall, we have inadequately addressed the economic tolls of this pandemic. But the real worry I have is what we do going forward. And my concerns are for the potential for there to be austerity measures that follow once governments see how much they have spent in responding to this. And really the lack of preparedness that we have seen in this pandemic in many ways is linked to the economic downturn of 2008, where governments tightened belts and cut budgets. And we saw a very clear erosion of public health programs, including loss of experienced personnel, furloughs, layoffs, et cetera. So I really hope we don't come out of this and then just lose everything that we've built over the last year. Just to kind of end on this, which is, what does it all mean? What does it all cost? This was, there was an article published in JAMA in the fall that estimated that the cost of COVID for the United States would be on the order of 16 trillion. I think that's probably now out of date given new stimulus and other things that the US has, and the wintertime surge of cases that we've seen. But just even if you accept that number as true, you need to compare it to how much we've spent on preparedness, which over a 9-year period was about $89 billion. And I could tell you most of that money was front loaded in the early years and continue to erode towards the later years. So this event has been a really devastating one. It is not the last one, though, unfortunately, that we are likely to experience. The frequency with which new pathogens are emerging is increasing. So it is highly likely we're going to find ourselves in a difficult situation sometime again. And the question is, do we want to be ready that next time, or do we want to have to continue to go through the devastating losses that we are now? To me, the calculus seems pretty obvious, but I think it's beholden on all of us in the medical and public health communities to articulate the value of investment in these critical programs and capacities. And because it affects all of us. I mean, I think every single discipline has been touched, including outside of health, business. I think there's probably not a person on the planet who hasn't been touched by this in some way. And so I just hope that going forward, all of us can be sort of champions for why we need to invest in these efforts. So while I'm there, thank you so much.
Well, thank you so much for that panel discussion. It was, everybody brought a really different perspective to this conversation, which I think just exemplifies all of the different ways that this pandemic has affected all of us. In the chat, there's been a couple of various themes, and so I'm going to sort of group them together in the interest of time. One of the things that we're seeing in the otologic community is a lot of post-COVID tinnitus, and some of that can be incredibly debilitating. Professor, have you guys seen that also with your patients in South Africa, and how have you managed some of that post-COVID symptom?
Yeah, thank you for that. That's actually a very good question. Yes, we have been seeing quite a few of that. And what we often notice is the tinnitus is sometimes independent of hearing loss. So it's an isolating presenting symptom. And you can either get tinnitus, vertigo, or hearing loss, or any combination of that. We've stuck to the usual management of tinnitus. Most of it is non-pulsatile tinnitus, so in that it's originating from the cochlea and the cochlear nerve and central system. So we've put them on medications to suppress it, and tinnitus rehabilitation. So that's what we've been using at this point in time, but it's very debilitating, and there are lots of patients out there that are really struggling with the tinnitus, especially these people that work with headphones. As you can see, I have one right now. So to have the tinnitus is really quite difficult. I don't think we've resorted to very drastic and extreme measures such as gentamicin and those kind of things as yet. In our institution, we're still managing them with the tinnitus rehabilitation. I hope that answers the question.
Yeah, no, great. It's been it's something that's come up a lot recently on our social media chat groups of neurotologists and otologists here in this country, and we're seeing it not only in the post-COVID setting, but also in the setting of the vaccines. And so people are reporting developing either sensory neural hearing loss or tinnitus in association, sort of temporally related with that. But I don't think anybody has the right answer yet. So, and then another set of questions came in, Dr. Voelker, about your telemedicine and telehealth project, and was there more satisfaction or dissatisfaction based on the kind of patients that the otolaryngologists were seeing? I know, like, I just basically said I can't do telemedicine. I have to look in people's ears. I can't do that.
Yeah, thank you for that. That's actually a really important point. This was a pilot study, so we were grouping all of our incoming subspecialists within otolaryngology, but it's definitely something that's really important to further analyze. Obviously, if you have a head and neck tumor, you can get pretty far as imaging is concerned and work up and get people down the line. But ultimately, all of us need to eventually examine the patient, certainly before taking them to the operating room. So I think that is very important. Our laryngology division is doing a lot with voice therapy and getting them rehabilitated over telemedicine. So Dr. Mike Johns is doing a great job really spearheading telemedicine within their division. So I think the sky's the limit as far as how we can be creative in the services we offer folks over this new platform. But ultimately, everyone here on this conference is a surgeon and needs to examine the person before. So that needs to be further elucidated. Thanks for that.
Yeah. The other thing that at least I struggled with, and I think is still an issue, although it's gotten better with the addition of closed captioning, is in the otologic sphere and in the audiology groups and our cochlear implant rehabilitation issues is this issue with hearing loss, right? And it becomes really hard on Zoom if you have a little lag and somebody is a lip reader. That's a problem for a lot of patients, and that's I think been one of the other challenges. Did you guys address that issue at all?
Yeah, it's interesting because our hard of hearing group of folks, our audiologists jumped in there right away. They were jumping in there right away, how they can get reimbursement for visits and also how they can creatively communicate with the patients. And actually, I found, aside from my physical exam, I like to do a lot of my preoperative counseling with my hard of hearing folks over the video because I could take off my mask.
Yeah.
They could see my face. I could get up closer and I could utilize the closed captioning. So I think thinking creatively about how we can combine the physical exam with our counseling of folks is really important. I could never find the masks that had the little see-through thing. They were all sold out. So
Right.
For me, I would do a quick exam. A lot of my patients live far away. They could go home. They could have lots of family members on the video and ask all their questions and incorporate closed captioning. So I think your initial question is really hit the nail on the head, that if we think creatively as physicians and surgeons and really tailor our care specifically for our subpopulations, it can only augment how we can take care of our patients.
Awesome, thank you. All right, I think we have maybe time for one more question, and that was for Dr. Nuzzo. You mentioned sort of some ways that you had been able to counsel people who were reluctant or resistant to doing vaccination. And so there were a couple of questions that came in through the chat about what's your strategy? Because we all run into them.
You know, I think it's there's no one strategy. You have to really read the person and meet them where they are. But starting from a place of empathy and recognizing that some level of hesitancy is a good thing. I mean, we want people to ask questions and to seek information. We just hope they seek it from the right sources. So I think that is a given. You have to be empathetic and start from there. It unfortunately, to have a good conversation, it takes time, which is really hard to understand in a clinical interaction. I will say that there are some common questions though. So kind of not rehearsing because nobody wants to feel like you're giving them a canned answer. But common questions are about, like a misunderstanding about, where in the body the vaccine is working, that they think it's circulating all over and it's depositing proteins in different parts of, in the body, particularly the reproductive system. Those are a really common set of questions. So I think there are actually, and it's really interesting because I think they're probably coming from very similar disinformation sources online. But I have found that people, when I've had the most productive conversations, it is when people have felt like I'm not judging them for asking those questions. That seems to be the most common thing, where they have in other interactions, perhaps in a healthcare setting, sometimes have felt that made stupid for asking the questions. And so reaffirming that, no, these are totally normal questions. These are common questions. And acknowledging when there's no answer. The other thing is just in identifying whether there's conflict of interest. So a lot of times it's like, do you have stock in this company? It sounds, but these are very common things. So for me, I don't have any interests. This is what I feel. I understand that you don't. And then one more thing. I have to say, we are underselling these vaccines and we are overemphasizing the risks to the vaccinated. And I know it's a very, nobody wants to say, this will never happen. But I think if you continue to paint a vaccinated future as one where you don't get to do anything and you're going to wear a mask for the rest of your life, it's honestly turning people off. Why would they bother? I think we have to speak with confidence that vaccines significantly make you safer. And there is no zero risk situation, but commonly, there will be a level of mask wearing and other things just because we need to maintain compliance at this point and there's norms going, but there is a future in which we don't have to do that.
Fantastic. Well, thank you again to my panelists. This was a really fantastic discussion. And I sincerely appreciate everybody's time. And thank you to the ANS for asking me to moderate this panel. It was a ton of fun. And so with that, we'll say goodbye and close the session. Thank you so much.